Welcome all to the first academic meeting of the year. You've probably seen the new platform, so we hope it's going to go down well, and hopefully we'll sort out the CPD points. So just on behalf of my division, the Division of Endocrinology, I'm just going to talk a little bit about practical approach to hyperlipidemia, lipid problems. I'm just going to go through a few cases because lipids, or we do have a lipid clinic at our hospital, but lipid problems are often mismanaged or not managed as well as they could be. Just see if I can forward my slide. So this is going back a good few years when we first started the lipid clinic. I mean, this is 20, 30 years ago. Patients used to have to come in at the beginning of the week. We would take blood samples and let them stand overnight, and we would then get these various patterns as shown on the screen here. So the red cells would move to the bottom, and the serum would give you these different patterns. This is called the Friedrichsen's classification. So normal serum is on the left of the screen, and then you have these different patterns. The typical pattern of familial hypercholesterolemia is what we call type 2A. But fortunately, we no longer have to do this, and we now rely on the laboratory, which can very rapidly give us a lipid profile. So our patients actually have their lipid profile early in the morning, and when we see them an hour or so later, we have their latest lipid results. And basically, based on the lipid profile from the laboratory, when we look at the lipid profile, we can see the picture is predominantly a cholesterol problem. If it's a mixed problem where both cholesterol and triglycerides are elevated, or if it's predominantly a triglyceride problem. And I'm just going to go through then a few cases illustrating mainly lipid problems, a high cholesterol, and then a high triglyceride. So this is the first case, a severe hypercholesterolemia. Mrs. TDK, a 50-year-old female, well, she had never smoked. No other risk factors for cardiovascular disease, but she had a positive family history, her father having undergone coronary bypass surgery at the age of 52. On examination, she did have the clinical features of familial hypercholesterolemia, arcus cornealis, as well as thickening of her Achilles tendons. So this was the first time a lipid profile had been done in her, and she had this very extreme elevated total cholesterol of 15.6. normal triglyceride and HDL levels, and a very markedly elevated LDL cholesterol of 13.2. So when we see a picture like that, particularly in our country, we have to think about familial hypercholesterolemia. And just to remind you all, it's the most common of the inherited gene disorders, affecting about 1 in every 300 people worldwide, or over 30 million people. So if we compare it to other sort of genetic diseases like cystic fibrosis, neurofibromatosis, you can see that familial hypercholesterolemia is much more common. These are the estimates around the world. We used to think FH affected about 1 in every 500 people, but as I've said now, the more accurate estimate is 1 in every 200 to every 300 people. So on the African continent, there are over 4 million people with this condition. It's an autosomal codominant condition. So if inherited from one parent, you have what we call heterozygote familial hypercholesterolemia. Your LDL cholesterol level is about twice normal, and coronary artery disease usually begins in the 30s and 40s. The more rarer form, homozygote familial hypercholesterolemia, is when you've inherited the condition from both parents. You have very few LDL receptors on the cell. Your LDL cholesterol levels is fourfold or even greater. And heart attacks begin in childhood. The youngest patient I've seen had a myocardial infarction at age 1. So this is just a little a schema showing the problem. A normal cell has about 80,000 LDL receptors. Heterozygote patients have about half the number of LDL receptors, and that's why the LDL cholesterol in the blood is about twice normal. Homozygotes have very few, if any, LDL receptors, and that's why they have the extremely high LDL cholesterol levels. We know a lot about the genetics now. The vast majority of patients with familial hypercholesterolemia have a mutation in the LDL receptor, over 95%, but it can be due to mutations in ApoB, which is the carrier protein of LDL, or more rarely gain of function mutations in PCSK9. So just to remind you of the clinical markers, and I think this is very important, any patient presenting with early onset of atherosclerotic cardiovascular disease, whether it be a heart attack or a stroke or peripheral vascular disease, should be examined for the clinical features. So this just shows arcus cornealis in the top left, and this is a young patient, as you can see. The top right, there's both arcus cornealis as well as xanthelasma around the eyes. But the most important clinical features are tendon xanthomas, particularly in the Achilles tendon, but also in the extensor tendons of the hands. So then just in summary, heterozygous FH, which is extremely common in our country, it affects 1 in 80 of the Afrikaner, Jewish, and Indian populations. LDL cholesterols are twice normal. Heart disease begins in the 30s, and patients respond very well to therapy, which I'll discuss shortly. The more rarer high homozygous form, the prevalence in our country is even higher, but it's about 1 in every 300,000 around the world. The LDL cholesterols are 4 times normal, and coronary artery disease begins in childhood. This is just a photo of one of our young patients with homozygous FH. This is often mistaken for warts, etc. But whenever we see xanthoma over the knuckles or between the fingers, you need to think of homozygous familial hypercholesterolemia. And many of such patients have been referred by dermatologists or pediatricians with this diagnosis. In the last 10 years, we've realized that the overlap between heterozygous and homozygous FH is greater than we previously thought. So you can have a heterozygous patient with very high LDL cholesterol levels. You can have patients with genetic homozygous FH with lower LDL cholesterol levels. So that's just shown here. The overlap is greater than we previously thought. But the bottom line, as shown in this slide, is that the poorer the LDL receptor function, so those homozygotes that have very poor residual LDL receptor function tend to have the highest LDL cholesterol levels and are at the greatest risk for coronary artery disease. So just reviewing treatment briefly, I'm going to just concentrate on the lipid modifying drugs. It's only for the very rare severe homozygote patients that we have to think about LDL apheresis, liver transplantation, etc. So when we look at the lipid modifying drugs, we can divide them into 2 classes, those that are dependent on LDL receptor function. So you need to have some LDL receptors for them to work. And then I'll briefly mention the LDL independent drugs a little later. So as we all know, statins are the first-line therapy. Remarkable drugs. They're underutilized, which I'll discuss a bit later. And interestingly, there's never been a study conducted in FH patients with the use of statins, but it's our standard first-line therapy for such patients. Just to remind you all how they work, statins inhibit a very important rate-limiting enzyme in the synthesis of cholesterol within the cell. So as a result, the cell cannot make its own cholesterol. It needs cholesterol for normal function, so it will upregulate the LDL receptors on the cell surface, pull in LDL cholesterol from the bloodstream, and that's why these drugs are very effective at lowering LDL cholesterol. Now, in most patients, high-intensity statins would halve your LDL cholesterol level, but what about homozygotes that have very poor residual LDL receptor function? And interestingly, these are some studies we did with very high dose simvastatin, atorvastatin, and similarly, we've done one with rosuvastatin. And the effect in homozygotes is about half. So instead of a 50% reduction, you get about a 25% reduction in LDL cholesterol, but homozygotes do respond. And this is more recent data from the Netherlands, which shows that even homozygotes with null mutations shown in the green triangles do respond to high-intensity statin therapy. So it's first-line therapy in all our patients. We then add a drug called ezetimibe, which is underutilized. And just to mention, now there are generics of ezetimibe, so it's much cheaper than it was previously. And that will result in a further 20% reduction in LDL cholesterol. This drug inhibits the uptake of cholesterol from the intestine. So for many patients, the combination of high-intensity statin, so that's atorvastatin, rosuvastatin at its top dose, together with ezetimibe, will halve your LDL cholesterol levels. And for many patients, that would be sufficient to attain the LDL cholesterol targets. So our patient was started on 40 milligrams of rosuvastatin, the top dose. You can see there was a reduction in her cholesterol, but it remains markedly elevated. We added ezetimibe, 10 milligrams to the rosuvastatin. She had a further reduction, but you can see the LDL cholesterol level is still markedly elevated, greater than twice what it should be. And this is the problem with many of our patients with familial hypercholesterolemia. Despite high-intensity statin and ezetimibe, we can get very few to the currently recommended targets, the 1.8 or 2.5 millimoles per liter. Less than 10% of our patients can get to these sort of targets. So there are newer therapies. Unfortunately, they're not available in the state sector. They are now, some of them are available in the private sector. The most important new therapies are the PCSK9 inhibitors. We have now available 2 monoclonal antibodies against PCSK9 called evolocumab and alirocumab. Hopefully within the next year or two, we will also have the siRNA gene silencing drug called inclisiran, which also inhibits the production of PCSK9. But this is just one study we're involved in patients with familial hypercholesterolemia that were randomized either to placebo or to the monoclonal antibody evolocumab. It's an injection given once every 2 weeks, and you can see the addition of this therapy reduces LDL cholesterol by a further 60%. So remarkable drugs, are very effective, and can get the vast majority of patients with heterozygous familial hypercholesterolemia to target. Unfortunately, because they're monoclonal antibodies, they are expensive. And in our country, they cost about 6,000 Rand per month for this medication. Would they work in homozygotes that have very little residual LDL receptor function? And interestingly, much like statins, in homozygous patients, PCSK9 inhibitors are about half as effective. So instead of a 60% reduction, we get about a 30% reduction in LDL cholesterol. But in homozygotes, it's very dependent on residual LDL receptor function. So if you've got defective mutations of the LDL receptor, so they're like deformed, they're not totally absent, you can get about a 50% reduction. If you have what we call negative or null receptors, this therapy does not work. Just to show you the long-term effect of this therapy, this is the study called Therapeutic. Shown in blue are the homozygotes, about a 30% reduction, which persisted over 4 years. In the heterozygotes, you can see nearly a 60% reduction, which also persisted for 4 years. So very effective therapy, but unfortunately it is costly. Anyway, our patient was enrolled into a study with this therapy at the time. And as you can see from her starting level, we eventually got her to a pretty normal lipid profile. This is just her time course. Her initial LDL was 13.2, and then we achieved an LDL cholesterol of 1.8 with a combination of statin, ezetimibe, and a PCSK9 inhibitor. Interestingly, part of the study was the genetics, and that's shown here. We thought she was a heterozygote, but her 3 sons had, in fact, 2 of them had 1 mutation, 1 had a separate mutation. So she was actually a homozygote patient. She had given 1 of the mutations to 1 of her sons, the other mutation to the other 2 sons. So she's actually a homozygote patient, but responded remarkably well to this triple therapy. Then just lastly, what about drugs that are independent of the LDL receptor? There was a previous drug called mipomersen, but that's no longer available. I'm just going to speak briefly about lamictal, which is not available in our country, and then the remarkable new therapy, which is called ANGPTL3 inhibition. So lamictal is a drug called a microsomal triglyceride transfer protein inhibitor. So that prevents the formation of lipid particles within the liver. So if you don't make VLDL, you can't make LDL. So it is pretty effective. And in homozygote patients, it can reduce LDL cholesterol by about 50%. The problem, however, is because you're not releasing particles, lipid particles from the liver, the fat content of the liver increases. So a side effect of this therapy is hepatic steatosis. And that's just shown in this diagram. Both these drugs, lamictal and mipomersen, although they effectively lower LDL cholesterol, the side effect is hepatic steatosis, and the concern in the long term is whether that can result in non-alcoholic fatty liver disease and liver cirrhosis. So what about the latest drug, and that's called ANGPTL3 inhibitors? ANGPTL3 or angiopoietin-like 3 is a very interesting enzyme which is very important in lipid metabolism. And we know from genetic studies and mouse models that if we can inhibit ANGPTL3, we can reduce all lipid parameters, cholesterol, triglycerides, and HDL quite effectively. And for that reason, drugs that are that can inhibit ANGPTL3 have been developed. And we were recently involved in a study with an ANGPTL3 inhibitor called evinacumab. It's a monoclonal antibody. It's given by infusion once a month in homozygous patients. And as you can see in this graph here, this drug resulted in a 40 to 50% reduction in LDL cholesterol. And interestingly, this drug works as well in patients with no receptors, shown in red here, as in those with defective receptors. So we now are able to get the vast majority of even our homozygous patients to LDL cholesterol targets, which I never thought would be possible 10 or 15 years ago. So this is just a summary showing the current therapies we use for severe hypercholesterolemia. At the top are the ones that are dependent on LDL receptor function, our standard first-line therapy, statins, ezetimibe, and the PCSK9 inhibitors. And then for the very difficult to treat patients, at the bottom are those that are independent of LDL receptor function. This is just a little algorithm for the treatment of severe familial hypercholesterolemia. First-line therapy is high-intensity statins. We add ezetimibe, and then we add the newer drugs that are becoming available to us. So just how about a second case? And although we must always think of familial hypercholesterolemia when we see very high lipid levels, we need to always think about secondary causes. This lady, Mrs. DG, 42-year-old female, actually used to be the venisector at our lipid clinic. And she thought she should just have her level measured because we were measuring lipid levels in all our other patients. And she was very surprised when her lipid profile showed a markedly elevated LDL cholesterol of 10.7, a total cholesterol of 13.2 with normal triglycerides and HDL. Importantly, there was no clinical stigmata of FH in this patient. And not really a strong family history of premature coronary artery disease. So whenever we see patients, we always have to think about secondary causes. And routinely at our clinic, when new patients are referred, we do thyroid functions, we do liver tests and a UNE just to exclude liver abnormalities and, for example, the nephrotic syndrome, and we take a history. And she had her thyroid functions done and was shown to be overtly hypothyroid. So in fact, we didn't treat her with a statin or ezetimibe, we just treated her hypothyroidism. It can take some time, but this is a lipid profile 6 months later, just with a thyroid hormone replacement, which returns totally to normal. So we must always think about secondary causes, and I've just listed some of them here. Whenever we have a lipid profile abnormality, There are endocrine causes like diabetes, hypothyroidism, Cushing's, obesity. There are renal causes. There are liver causes, which can all cause severe hypercholesterolemia. And then there's some other conditions. And what we've always got to think about is drug therapy, which I'll allude to in the next case I show you, but importantly, antiretrovirals, the retinoic acid derivatives like Roaccutane. We must always think about alcohol, and interesting conditions like anorexia nervosa or bulimia can cause severe hypercholesterolemia. So taking a history of drug use and thinking about secondary causes is always very, very important. So I'm now going to change track and I'm going to go to the other side of the spectrum, looking at a patient with very high triglycerides. This is a 39-year-old male who presented with some epigastric discomfort. He thought maybe he had a reflux or a peptic ulcer. He had been aware of a high cholesterol for many years, but he didn't smoke. He had a stressful job. I'll come back to that in a minute. He had been hypertensive for the past 4 years, and his body mass index was 30 kilograms per meter squared. So he was overweight, but not morbidly obese. When he was referred to our lipid clinic, his therapy at the time was simvastatin 40 milligrams daily. He was on a combination of a beta blocker and hydrochlorothiazide for his blood pressure. And because of his epigastric discomfort, he was on a PPI, omeprazole 20 milligrams daily. This was his lipid profile. The lab told us that the serum looked lipemic or milky. You can see his cholesterol is elevated, but he has a markedly elevated triglyceride level, a low HDL. When we have such high triglyceride levels, you're unable to calculate LDL cholesterol, so that's not reported. His glucose was normal, his thyroid functions were normal. But as I said, we do a series of tests for our patients at Lipid Clinic, and this was his liver functions. ALT, AST were in the normal range, but he had a markedly elevated gamma GT. So when we see lipemic serum, we need to think there are underlying genetic causes, but these are a very small percentage. So less than 10% of cases are due to genetic causes like lipoprotein lipase deficiency, ApoC2 deficiency. The vast majority of cases of hypertriglyceridemia are probably an underlying common genetic disorder, but there's usually a secondary hit, a secondary cause. So diabetes, alcohol abuse, hypothyroidism. So we must always think about underlying secondary causes when we have patients with lipemic serum or severe hypertriglyceridemia when the triglyceride level is greater than 10. This is just what his serum looked like. So normal is on the left. That's normal serum. You can see his serum, which is on the right, looks like a cream on top of a nice Irish coffee. This was just his back. You can see these are the typical what we call eruptive xanthomas. They look like a little chicken pox, but they have a little white center. These are what we call eruptive xanthoma, which we see with severe hypertriglyceridemia. A very important clinical sign is also to look into their eyes. A normal fundus is on the left. In somebody with severe hypertriglyceridemia, the vessels look white instead of red, what we call lipemia retinalis, and it's a very important clinical clue to the diagnosis of severe hypertriglyceridemia. Anyway, so what did we do with this patient? His stressful job, he happened to be a policeman and he was drinking excessively. So we advised him to cut back on his alcohol. We also stopped the beta blocker and thiazide because both of those drugs can cause severe hypertriglyceridemia. We stopped his simvastatin because statin is not the correct drug for severe hypertriglyceridemia. We gave him an ACE inhibitor for his blood pressure, and a fibrate is a more appropriate drug for severe hypertriglyceridemia. And 4 weeks later, you can see there was a marked improvement in his lipid profile. His triglycerides are still mildly elevated, but there was a marked improvement despite having stopped the statin. So the correct drug for the correct patient is important. So this is just our approach to patients with elevated triglycerides, where you can divide it into the two sort of categories. We worry when the triglyceride levels are above 10, because there is a greater risk of pancreatitis. So high triglycerides are associated with the risk for pancreatitis. And the primary goal is to try and prevent pancreatitis. So there we've got to look for secondary causes. The first-line therapy is a fibrate, and there are newer drugs under development, but like ApoC3 inhibitors, but these drugs are only for the severe patients with underlying genetic causes. What about patients that just have moderately elevated triglycerides, less than 10? In that category, most important is diet and lifestyle, because many patients with mildly elevated triglycerides, if they are overweight and lose weight, they will reduce their triglyceride levels. Here, the primary goal is to try and reduce cardiovascular risk. And importantly, it's to get the LDL to target. So in patients with mildly elevated triglycerides, first-line therapy is still a statin, because that does reduce triglycerides as well as cholesterol. So this just shows the atherogenic risk of triglyceride risk particles. They tend to be small and dense, and we classically see this in patients with the metabolic syndrome or type 2 diabetes. First-line therapy, as mentioned, is always a statin to try and get them to target. If we're not at target, we would think about adding drugs such as a fibrate, but unfortunately, fibrates have not been shown to be of cardiovascular benefit, the ones up to date, that is. There is a newer fibrate, a big study is being done called the Prominent study with a newer fibrate called hemafibrate. And if that does show cardiovascular risk reduction, that will be used. We can also use the newer drugs not available in South Africa yet, but the omega-3 preparations like isocopent ethyl. A study called the Strength study showed cardiovascular benefit with adding omega-3 preparations to statins in patients at high cardiovascular risk. So just lastly, just to end off with, what is more important? Is it LDL cholesterol? Is it remnants and triglycerides? Just to remind you all that in the fasting state, the vast majority of circulating lipids is LDL, which is shown in blue here. So in the fasting state, most of us will have very little remnants, very little VLDL or RDL. So triglycerides are not a major problem in patients if they adhere to a good diet or if they're overweight and they attain their real weight. And for this reason, all the guidelines around the world are still directed towards treating to an LDL cholesterol target. And this is the latest guidelines which we have adopted in South Africa. You can see very high-risk patients shown at the bottom in sort of the rusty color. If you've got established atherosclerotic cardiovascular disease, if you have severe chronic kidney disease, or you are diabetic with target organ damage, your LDL cholesterol should be 1.4 or less. As you go up the scale and your risk is less, the targets are naturally higher. But everyone should have an LDL cholesterol of 3 millimoles or below. So this is the current recommendation. We need to reduce LDL exposure. We need to treat aggressively. And to do this, we need to actually think about starting with combination therapy up front. So if we need to get these newer targets, we often need to use combination therapy right up front. So if you think about the way we used to treat hypertension, we used to start with one drug, then we'd add another, then we'd add a third. But as you know, for management of hypertension, we now often start with combination therapy. A calcium channel blocker plus a diuretic, a calcium channel blocker plus an ACE inhibitor. And exactly the same is happening in the lipid field. If you see a patient at very high cardiovascular risk, right up front, we should think about starting combination therapy. We should think about a combination of a statin plus ezetimibe like we do in hypertension. If we're unable to achieve the targets in our high-risk patients, that is when we should think about the addition of PCSK9 targeted therapy. Unfortunately, it is costly and it's not available at the moment to us in the state sector, but hopefully things will change in the future. So just in summary, I've just tried to let you all know, given you some cases to illustrate that LDL is still the pivotal risk factor for cardiovascular disease. On the other hand, extremely elevated triglycerides predisposed to pancreatitis. In these patients, we have to exclude and treat secondary causes. But in order to reduce atherosclerotic cardiovascular disease, we need to be more aggressive in lowering LDL cholesterol. And as in treating hypertension, we need to think about first-line combination therapy in our high-risk patients. So I'll stop there, but I'm very happy to answer any questions. I see there are a few on the chat.